Hello, everyone, and welcome to the 2023 ADA Standards of Care Diabetes Technology Update. My name is Diana Isaacs, and I will be moderating today's session. I'm an endocrine clinical pharmacist and also the Director of Education and Training in Diabetes Technology and the co-director of Endocrine Disorders and Pregnancy at the Cleveland Clinic. And none of this would be possible without the guidance of ADA's Time and Range Advisory Group. So we'd like to thank the members of that group for their hard work in developing today's program. We're also very grateful for the support of Abbott and LifeScan, who made this program possible. So let's see who we have joining us today. Please let us know where you're from. If you want to go ahead and type in the chat box your organization and the state that you're joining from, that would be fun so we could kind of see who is all here. We're going to try to keep this really interactive today. So please use that chat and let's see where you're all from. I'm seeing Minnesota. Wow, Morocco. All right, Colorado. We've got Chicago, Ohio, yay, Missouri, oh my gosh, Florida, I can't keep up, New York, okay, we've got lots of people, that is wonderful. So thank you everyone so much for joining with us today. And with that, I want to just highlight some of the ADA membership benefits. And so becoming a member of ADA provides many opportunities to network and grow professionally. ADA memberships include a variety of professional membership benefits, and that includes things like meeting discounts, the Women's Interprofessional Network, all the special interest groups, Diabetes Pro Member Forum, the professional journals like Diabetes Care, member-only webinars, the member directory, the standards of care in diabetes, Diabetes Pro Quarterly, and many other amazing things. So you can visit the website that will be in the chat if you're interested in membership, if you are not already a member. Now, will you accept the challenge? Test your knowledge in Time and Range's free case study challenge for a chance to win a one-year ADA professional membership. So you can sharpen your skills with these quick case studies exercises and earn points, have fun, learn something new, and discover relevant resources that can support your practice. And you can enroll today at the QStream, diabetes.qstream.com. And Time and Range actually has a new home. So access all the content on ADA's Institute of Learning, and you can view recorded webinars like this one, podcast episodes, practice Pearl videos, and infographics. You can use the link here to access all this content after the webinar. And at this time, I'd like to go ahead and introduce our speakers for today. We're going to be spending time discussing Section 7 of the Standards of Care of Diabetes Technology. And we're going to keep this really interactive. So please utilize the Q&A, the chat. We don't have a lot of slides prepared because we want to answer your burning questions. So to do that, we have Dr. Grazia Aleppo, who is a professor of medicine in the Division of Endocrinology, Metabolism, and Molecular Medicine at the Feinberg School of Medicine, Northwestern University, Chicago. She is also the Associate Chief for Clinical Affairs in the same division and the Medical Director of the Northwestern Medicine Diabetes Training and Education Program. Dr. Aleppo has participated in the major clinical trials on the use of CGM in various populations and automated insulin delivery systems. With over 80 publications and book chapters in peer-reviewed journals, Dr. Aleppo is considered a prominent national key opinion leader in the field of diabetes technology, including insulin pumps, CGM systems, and automated insulin delivery. Also with us, we've got Dr. Viral Shah, who is an associate professor at the Barbara Davis Center for Diabetes, University of Colorado, Anschutz Medical Campus. Dr. Shah has been the PI for many clinical trials of diabetes technologies and therapeutics. He has been a part of landmark research such as Replace BG, Wisdom, Artificial Pancreas, Cambridge, Omnipod 5, and Dexcom G6 pivotal trials that led to FDA approvals of newer devices and have changed the lives of people with type 1 diabetes. Moreover, his interest in understanding the effect of diabetes on bone fragility has led to 2 NIH-funded studies investigating the effect of long-standing type 1 diabetes on bone tissue material properties and factors affecting bone density, bone mechanical properties in adults with type 1 diabetes. He also serves as the editor-in-chief for Clinical Diabetology, senior editor of the Endocrine Connections, and section editor for Current Opinion in Endocrinology, Diabetes, and Obesity. He is well published with over 150 research publications, including original article, invited reviews, editorials, and book chapters. So thank you so much to Dr. Naleppo and Dr. Shah for joining us today. So the next thing I'm going to do before we talk about the specific sections is I just want to give a very high-level overview of what the standards of care are all about. So these are updated annually, and these are based on the highest level of evidence coming out. And so if you're not familiar, this is just the level of evidence table. Level A is the highest level of evidence when we have well-designed randomized controlled trials. And this goes all the way down. A, B, C, and E is based on expert consensus. When we may not have well-designed trials, but still the experts in the field feel it's strong enough to make a recommendation. And the guidelines are based on evidence with a multidisciplinary professional practice committee, and recommendations are revised per the new evidence each year. And also just want to highlight that this is funded out of ADA's general revenues, so it does not use industry support. At least half of the members do not have conflicts, including the chair does not have any disclosures or potential conflicts of interest. And this is the Professional Practice Committee. It is a very diverse, multidisciplinary committee. I had the great privilege to serve on this committee over the past 3 years, including in the past year with Dr. Aleppo. And so it's a a great committee where you just hear lots of experts discussing the latest research. And then I also just want to highlight that this is a living document. So every year it's updated. But also, if there's new literature that comes out, then there's actually living updates that can happen throughout the year. So it truly is a living document. And there's also a mobile app as well to stay updated on all of these guidelines. All right, so I have done enough talking now. So I'm going to turn it over first to Dr. Aleppo, who is going to provide the updates and blood glucose monitoring. I also just want to remind you, if you have questions or comments on this section, please utilize the chat. We've got a lot of you here. Please comment and ask questions. And with that, Dr. Aleppo, it is all yours.
Thank you so much, Diana. What a privilege to be in this webinar together with you and Viral Shah, dear friend, a wonderful colleague of mine, as well as you. We worked so close together last year. It was quite a lot of work at the first time for me, but so much learning throughout this wonderful practice committee. And so let's talk about blood glucose monitoring. Recommendation 7.6, people with diabetes should be provided with blood glucose monitoring device as indicated by circumstances, preferences, and treatment. But also people using CGM must have access to blood glucose at all time. This is an important thing because we need to remember that even though we have great CGM systems today, they still might have half an hour, 2 hours, however many hours of warming up time. And there are always circumstances in which the person with diabetes might not be sure that the number on the sensor is correct for a variety of reasons. We discussed later on some interfering substances, but most importantly is what if the person has a hypoglycemic episode and their symptoms do not match what the sensor says? That is the perfect place when people with diabetes should be able to use a glucose meter. And that's why they should not be removed from the coverage from third parties. So that's one very important thing. And then the one thing that we sometimes don't think about too much is that they should be aware, us as providers, of the differences in accuracy among the blood glucose meter, not only from the US FDA and also with proven accuracy. I'll explain to you why. So there has been a great movement to trying to have all these quote unquote free glucose meter to be given to people with diabetes, especially the ones who are on Medicare. The problem is that some of these glucose meters, or even some of the pharmacies named brand that are from the category, the umbrella is under the Nipro brand, unfortunately are not accurate enough. And there were two major papers that were published in the last 4 or 5 years, the one actually more recent, that show that only a few glucose meters actually meet the criteria, not only for the ISO, which is the European standard, but most importantly from the FDA and also from the verification done in particular studies to verify these meters. So for us providers, it's very important that the patients are given accurate glucose meter. And there are very few out there, but they have to be accurate. If you don't have accurate glucose meter, you might have really inconsistent data, and then you can have serious problems, especially if you're administering insulin based on that one number of glucose. I see a lot of chats, a lot of questions coming up. Diana?
Yeah, so it looks like there's a question in the chat about if CMS or Medicare covers blood glucose testing equipment for CGM users.
And that is a challenge. Thank you, Diana. Unfortunately, as of right now, I hope these things will change. Very often, when the patient has coverage for CGM, the coverage for blood glucose meters and strips stops. And so I've had to have my patients go to Amazon or to Walmart to get a particular brand that is actually pretty accurate, that is they rely on, because they don't have both coverages. And that's why we, in the recommendation, the standards of care, we say the patients using CGM must have access, because even though we are very accurate CGM systems today, we need to be very aware of the fact that sometimes things happen, and you might not have a sensor because it doesn't get into the mail. Many things may happen. And so you need to be able to immediately verify your glucose without having to have this expense to be out of pocket. So there are situations in which it is still necessary, although not very common, to occasionally check the glucose levels.
Great. And there's some questions on CGM, so I'm going to hold that off for the next section.
For later.
But I do have a question. Does the technique matter, in terms of how you check your glucose?
Very. See, that's from the educator in you. And I love that you asked this question, because so many times there are pieces of fruit on our fingers, lotion, soap. So yeah, very important. We need to train our patient to check the glucose correctly. Wash the hands, make sure they're dry, there is no water, alcohol. Make sure you wipe the first drop and get the second drop of blood. That's how you really do proper technique of glucose monitoring. So this is not obsolete. It is still very pertinent and very important today, because we need to make sure the patient knows how to accurately check their glucose level. Thank you, Dana, from asking, and the public for asking this question. It's very, very important.
Awesome. And then there's just one other question. Someone's asking if there's a way to test glucose by using smartphone apps.
So it depends. There are some of them, but I don't think it's just by smartphone app alone. What happens is the many glucose monitor today have an app on the phone that records the glucose through either Bluetooth, and some of these phones have the app relative to the actual brand of the glucose meter. But to my knowledge, you can't just measure the glucose with the app. You have to have a meter and then the meter transfer the information. And the good thing about these apps on the phones are that you can then review the glucose, send it to the provider instead of this, blood-filled paper calendars with all the numbers that are so disorganized, because it gives also the user a lot of information in terms of, what is the target, how many times they are within the target, above, below, a lot of good pre, post meal. It's very good information for those who are still using solely blood glucose monitoring.
Yeah, I totally agree. It can make it easier to share the data, having those mobile apps. Great. Well, someone just put a comment in their prediction that we're going to have wearable devices in the future to monitor glucose, like watches. So we'll see if that comes to reality or not. So hopefully it will. We'll just see how soon. All right. Well, any other comments on glucose monitoring before we go to, I think, the really exciting stuff, the CGM and pumps? All right, we will dive. I'm going to go ahead and turn it on over to Dr. Shah to talk to us about CGM updates.
Yeah, thank you. Thank you, Diana, for an introduction. It's a pleasure to share this virtual stage with you and Grazia, a good friend. Thank you, ADA, for doing this webinar. Look at this, 271 participants. That's an amazing audience, and I see those questions flowing in. So please keep your question coming in. Let me just, put one clarification here that standard of care diabetes technology section, which is section 7, do have a lot of recommendations from the insulin pen and syringes, connected pens to BGM, to CGM, to AID system. But for the sake of a time here, we just selected only few key recommendations that we think would be of interest to majority of you. So what I'm going to talk is that about the ADA recommendation standards of care around the CGM. That's a continuous glucose monitoring. I don't want you to read this slide. I'm going to just go through quickly in a simplified manner. So we all see patients with type 1 diabetes, type 2 diabetes, and we know that type 2 diabetes is a heterogeneous disease from a pre-diabetes to type 2 diabetes requiring oral medications or GLP-1, SGLT2 kind of medication, injectable therapies to insulin therapy. And so the ADA standard of care recommendation about the continuous glucose monitoring spans from all people with type 1 to different types of type 2 diabetes. So what the ADA standard of care recommends that everyone with type 1 diabetes or type 2 diabetes who is on a multiple daily injections or a continuous subcutaneous insulin infusion, which is insulin pump, should be offered a continuous glucose monitor. The evidences are strong for real-time continuous glucose monitors. So that's a level A evidence. That's the strongest, as Diana already explained to you, or the intermittently scanned level B evidence, which is still strong, not strong enough. What about people with type 2 diabetes who are just on a basal insulin? So for that, again, we do have a strong evidence, level A, to suggest that we should use the real-time continuous glucose monitoring for people with type 2 on basal insulin. Intermittently scanned is the level C evidence. But again, ADA standard of care clearly recognize the value of CGM for people with type 1 and type 2 diabetes on different types of insulin therapy. Next slide, please. What about the people with, there we go. Youth with type 2 diabetes. So now we know that type 2 diabetes is not a disease of, you can call middle-aged or older adults with type 2 diabetes, older adults. It's also a significant problem, and it's a rising in terms of both incidence and prevalence in a youth. So in youth with type 2 diabetes, again, we do not have a strong evidence, but the committee feels that it should be offered. So real-time or intermittently scanned continuous glucose monitor should be offered to the youth with type 2 diabetes. What about pregnancy with diabetes? Again, not level A, but it's a level B evidence that, again, it definitely would help during pregnancy to improve glycemic control and thus both maternal and fetal outcomes. And again, the evidences are coming in. So, and this is a living document. So I'm sure that in near future, this level of evidence will change from B to A. So again, pregnancy, it's recommended. Youth with type 2 diabetes, recommended. Next slide, please. What about people with type 2 diabetes who are not on insulin? They are just on oral medication or injectable medications like GLP-1 analogs. Those individuals, again, we do not have a strong evidence, but it's a level C, that periodic use of real-time continuous glucose monitor, where you can use that 1 or 2 times. Patient can use that before comes to the clinic so that you can get the data. You can discuss that with your patient and improve the outcomes. Or you can use the intermittently scanned or professional continuous glucose monitor. As it has to be individualized. It depends on what your patient has a preference about and what do you think is going to be valuable to you and your patients. But again, it's recommended by the ADA standard of care. Now, when we use the CGM, just make sure that all the patients are educated on potential substances that can interfere the accuracy of continuous glucose monitoring. So this is very vital. And Very briefly, I will touch on that part. So let's say, for example, Dexcom G6, G7, there is no acetaminophen interference unless the patient is using more than 4 grams per day. That's a lot of acetaminophen. In Freestyle Libre system, that's across all the Libre system, the vitamin C has an interference where it can potentially give you a falsely high value when the vitamin C is 500 milligram or more. With the Eversense, that's the implantable CGM. There are certain substances like mannitol that can interfere with the CGM accuracy. Hydroxyurea for patients who have a cancer receiving this cancer therapy may interfere with Dexcom as well as the Medtronic sensor. Medtronic sensor still has the acetaminophen interference regardless of the dose of the acetaminophen. So anyway, this is very, very important that we educate our patients, because if they are taking this kind of a medication, the reliability or the accuracy of the sensors, it may not be that best. So we should keep that in mind. So I think that's all about the CGM. And again, as I mentioned, it's just I highlighted very key recommendations from the standard of care. There are many more. And if you are interested, I would highly recommend that you should read this standard of care document.
So we've got lots of questions coming in.
I know it's coming in. Yeah.
So I'll try to sift through them. So one of the questions was, does every person with a CGM, should they have a BGM, a blood glucose monitor? And how often do you need to be confirming readings with it?
I would 100% agree with what Grazia already mentioned earlier, that now remember that there are many situations CGM may not be accurate. Or sometimes the patients may not get the CGM continuously because of insurance issues, cost issues, something else. So I generally prefer, and that's the standard of care here, that's what it recommends, that every patient should also be given a BGM for various reasons.
So I know you do a lot of research with accuracy. So one of the questions was, well, kind of like, how accurate are these devices?
Sure. And I will just tell you that in a very simplistic way, we all are used to hear MARD. That's the mean absolute relative difference. And lower the MARD, the better it is. But in my opinion, and I say my opinion, quote unquote, is that MARD has become more of a marketing tool. So the really nice research paper from University of Virginia says that if the MARD is below 10%, whether it's a 9% or 8.9% or 8.7%, it really doesn't matter in terms of automating the insulin delivery system. So as long as the CGMs are less than 10% in MARD, all the CGMs are, in my opinion, are accurate, they are good. Now, remember that there are many circumstances that they may not be accurate. Again, we discussed some of the interference. So that's why we need to have a BGM, and we need to educate our patients when to do the BGM if needed.
Great. And someone's asking if you can talk a little bit more about aspirin and vitamin C drug interference.
A good question. And I already kind of highlighted earlier, the vitamin C interference is there with the Freestyle Libre system, and that's with the Libre 1, 2, and even 3rd generation. I think it's in a public knowledge now that they submitted to the FDA, possibly in future device, that interference will be removed, but currently it's existing for Libre, not with other sensors at this moment.
And just to add, for the aspirin, there was an issue with the very first Libre family. I think it was the 10-day, which of course doesn't exist anymore, but there is no interference with aspirin to our knowledge. But the vitamin C is still available, is there. And so we will see what the FDA decides. Of course, we would like to have as many sensors available to our patients for integration with pumps, but of course that is up to them to decide whether there is something to be included or removed. We just wait for what they will decide in the regulatory bodies.
Yeah, and just to add, it is doses of 500 milligrams or more. So the vitamin C from food, we certainly don't expect that to interact. It's people taking the higher dose supplements. So
correct.
There's a lot of questions about coverage. And I know it can get a little, dependent, but any kind of broad information about the overall coverage, like Medicare coverage for CGM?
I can start with the Medicaid, and probably Grazia, you can cover the Medicare part.
Sure.
Again, the Medicaid it's kind of a state and federal, right, combination, and depends on a state to state. But I would just say that overall, things are changing in a right direction. Think about that, how many states are approving CGM. I'm from Colorado, and in Colorado, the Medicaid in both kids as well as the adults approves the CGM. So now no more the patients that has to really, wait to get the CGM when they have a type 1 or type 2 on insulin therapy.
So thank you, Viral. There are more than 30 states in the country where Medicaid covers CGM. Some restrictions are as far as who can prescribe the CGM for these patients, and very often the restriction is for endocrinologists only in many states. We're hoping that this will change. There will be a much wider access in all the 50 states of the country for CGM patients on Medicaid, because they are the ones who actually most likely need the most. But as far as Medicare, we have coverage for everybody on insulin. It doesn't have to have the 4 sugar per day anymore, thankfully. No 60 days of glucose logs, can be 3 or more injections or on insulin pump. And this will change in July 2021. We have been working with some caucuses and some advocacy groups with Medicare to change the even the coverage for basal insulin only. And in fact, during COVID, very often we've had the chance for some patients on Medicare on 1 insulin injection only on basal to have access to CGM. Now, this, once the emergency ends, a concern is this patient might not be able to access any more CGM, the ones who are on basal only. And so there is a hopefully move to change in the language to hopefully Medicare will, there is a change in ongoing to put this in hopefully into action maybe at the end of the year to have the patients on 1 injection only to be allowed to use CGM, but of course are waiting for this to become effective. And we have been writing through Endo Society, to ADA especially, through other societies to ask Medicare to try to make this implementation as soon as possible, because we don't want patients who were through the emergency able to get these tools, not be able to get it anymore once the emergency is going to be over in May. And so we're just waiting very eagerly to hear from Medicare for the change in language to expand the use of CGM for type 2 on basal. The data are there. So we're waiting for that news very eagerly.
Thank you.
And I just see that in a chat field, Andrea actually put a post from an T1D exchange. So that link, actually, if you click that, it takes you to like which state is covering the CGM. It's nice information for our audience. So thank you for doing that.
Yeah, I can comment in Ohio, we're really fortunate. Medicaid covers CGM for any person with diabetes. It doesn't even matter the type or the medication. So we've come a very long way. There is a comment or actually a question about inpatient use of CGM. And if you think we'll get to a place where we can actually dose off of the CGM readings in the hospital.
Sure, and I can start, and Dr. Aleppo, you can probably add more to that part. So in ADA standard of care, we do have recommendations around the inpatient's use of CGM as well. Again, we know that we do not have a great evidences at this moment, but there are many studies. If you go to the clinicaltrials.gov, you will find that many studies are right now underway to look at the accuracies of CGM in a non-ICU setting first. Yes, there are some studies in a surgical settings and ICU settings as well. But I do believe that in near future, we will have enough evidences to say that, and we might see some approval as well in the future for the use of CGM in a non-ICU setting.
Yes, and Viral and I just came back from Berlin for the conference, the technology conference. There was so much talk about inpatient CGM. Of course, before this information to go into the guidelines, we had to have evidence-based. And so we're eagerly waiting for these data to be published so we can corroborate and say, okay, it is really something very important. One thing to say, though, that the Endo Society published the guidelines on hypoglycemia treatment, and they do recommend that patients in the hospital who are at risk for hypoglycemia rate use their CGM should be allowed to continue to use it. Because again, when somebody is used to have the security of the the alerts and the alarm overnight when there is no measurements of glucose, even in the hospital for many hours from 9 p.m. to 5 o'clock in the morning, they really would count on that glucose to alert to avoid patients who have hypoglycemia. Every hospital has their own policies, but I definitely support the fact that if you have your own CGM, you should be allowed to at least use it, even though if it's confirmatory glucose from the nursing staff. I definitely agree with that. But at the same time, if I had diabetes, I want to know if I'm going hypoglycemic at night, and I don't know if I would relinquish that CGM before I go into the hospital.
So there's a good comment. It says, can we dream of CGM like ECG monitor on a screen? So
I'm dreaming already, but we got to wait for the day.
So I like that. So someone was asking about compression lows when sleeping, if that's something that you mentioned to patients.
Go ahead.
Yes, and I would say the answer is yes. And there is a classical characteristic or the patterns that you will see on a CGM, that there was a sharp drop, and the drop is only for a couple of probably minutes. Because remember that depending on what kind of CGM you're using, let's say, for example, Dexcom, it's a 5 minutes each dot, Libre, it's a 1 minute. And you will see that suddenly it's coming back because the patient might be turning on the other side. And so compression lows are real, but would that affect diabetes management? My answer is no. And so probably I just ignore. Yes, I do explain the patient if the patient is concerned about that, or just to an education purpose. They should know everything about what they are using and how the system is working. But I also tell them that, depending on these things, whether need to be worried about or not to worry about. But also I emphasize that in nocturnal time, making sure that they are safe. So if it's, there is some symptoms or not matching with the CGM numbers, make sure you do confirmatory glucose testing rather than just relying on a CGM number.
Yes, Vera, I agree, especially because we need to remember that training is so important, so crucial. These are simpler and simpler systems to use, but important thing is to understand what a sensor does and does not do, because if you're not aware of what it can or cannot do for you, you might misuse it. And so that's where we need to be. Always remember that the education is crucial. And I think that is the most important thing about having a patient using a tool like a CGM.
Yeah, in ADA standard of care, we mentioned that education is in paramount importance, right? So even though we didn't include that line here, but that's what it says in a standard of care, that education is the key, whether it's a CGM, whether it's a BGM, whether it's an AID system. So
I completely agree. Yeah. And someone just made a comment that out of, Charlie made this comment about how out of ATTD last week, there was a lot of emphasis about CGM and type 2 diabetes. So
definitely.
Yeah, so that was very exciting to see. So someone asked a question related to data interpretation. How do you know, should you go off of a person's A1C, or should you go off of the glucose management indicator or time in range from the CGM report?
I can start again. I think this is a very important question, and we have published a couple of papers around that part. The first thing that we need to remember, and I think I'm quoting this Earl Hirsch actually wording says it is that the enemy for people with diabetes is the glucose, not how we are measuring it or how we are actually representing that number, right? We treat the patient, not the number. So A1C has limitations. Similarly, the time in range also has a limitation. Someone can say that time in range is pretty wide, 70 to 180, right? So again, when we see our patients, we are looking at everything. That includes time in range, time below range. And Dr. Alapo actually published a paper on how to really analyze the AGP data. And that analysis doesn't depend on one number or one metric. It depends on the overall profile of the CGM. And so in my opinion, I would say that you have to take everything into the consideration. Now, just a couple of wordings about the GMI. Sorry, I'm taking time a little bit here, but GMI is a linear regression formula, meaning by that it's a mathematic formula to look at what is the estimated A1C look like using the sensor data. And it's a math, it's not a physiology, right? So you will find some discrepancy between A1C and GMI. And that's nothing wrong about that part, in that case, again, you're not looking at only A1C or GMI. You're going to look at time in range, time below range, time above range, glycemic variability, that's the standard deviation or coefficient of variation. So You are managing a patient with diabetes rather than those numbers. That's my take home here.
And to add to that, we need to also keep in mind if a patient has kidney disease, you do know that the A1C is really very unreliable. So in those situations, I find that the glucose levels and the time in range, of course, below range, and the GMI are much more reliable because we can't trust the A1C for a million reasons. It can be too low, too high. It just doesn't make any sense. And so for those reasons, you want to monitor those numbers, but also remember, as Viral is saying, it's not just one. Yes, you could look at GMI or A1C, but even if it's a discrepancy, it's usually very consistent. So we need to teach the patient, because what I go by is the glucose. The glucose doesn't match the A1C. I explain to the patient why that is. And so we need to also not make the patient sometimes overly happy that A1C looks so low, because I want to make sure that there's no hypoglycemia. So a number is to be put into context. By itself, unfortunately, has no meaning. We put too much emphasis on just the A1C alone, and no longer is the case, in my opinion, but also is to be corroborated by the glucose. They're the match, then something is not really making sense.
Great, thanks. So I'm going to ask one more question on this topic, and then we'll go to the next on insulin pumps. The next question is related to upload access. Someone's asking about CGM data in the electronic health record, if that is how we can ensure that happens, and kind of where are we in terms of progress of that?
That requires a lot of work. So I've been fortunate to work with a wonderful team that has been trying to achieve this integration. And we have been able to do this so far with Dexcom. So our team of engineers in Northwestern Medicine has been able to get the API and move it into Epic. And so it's a continuous. We're doing a pilot right now to ensure the data is correct, comes at the right time, and then we'll then enhance it to our colleagues gradually, first with the endos and then with the primary care, with training material and stuff like that. The issue is there is a lot of, it's a big boulder to lift, and it depends on the institution, on what the medical record system is, and how to get the information. Right now we have only one brand, I'm hoping to get more brands, but this is something that doesn't depend only on me as a provider, but it's really a huge teamwork. It takes really a big village to take this and move it on. But I hope that for example, IDC is doing this through Libre for now, for Abbott. So some places in the country are trying to do this, but I hope that we'll be able to hopefully make this work for a lot more people, and so that if it works for us, that we can show other people how it can be done. But it's really a bit in infancy right now. I don't think there are many centers in the country who have an ongoing. I know that we are just doing a pilot, and I saw the ADC is doing a bit more because it started much earlier, but they also try to do something, just optimize the whole system. It really is a work in progress, but I'm hoping that many more people can do this. It's wonderful.
Right, and I just would like to add to that part is that, like, for example, think about the time in range, right? It took us a long time. The first consensus actually happened in Tampa, Florida, at the JEB Center in 2012. And now we are accepting that, right? So things, unfortunately, in healthcare move slowly. And we all understand how important it is for us to have a CGM integration into the EMR. So the first step is to making a standards around that part. And so the I code, it's an ICODE by the Diabetes Technology Society, has now put forward a very comprehensive guidance on how that connection between the CGM data or the portals with the EMR should look like. And hopefully that will move that kind of one step further forward for both the industry, the regulators, as well as the hospitals to think about how to integrate that part. But I am really looking forward to that integration because I know we all are really want that.
Yeah, and I'll just add, I mean, it's also complicated because there's so many different data management systems that go with different products, and some work together, but some don't. And so that adds a layer of complexity. All right, so now we're going to go to our third and final topic, which is insulin pumps and automated insulin delivery. And I'm going to turn it back over to you, Grazia.
Thank you, Diana. So now we're at the last part of our webinar today. And so 7.24 states really that AID systems should be offered to youth and adults with type 1 diabetes. Evidence A, there's plenty of data out there that this is a very, very helpful system, but also all the types of insulin deficient diabetes with evidence E, because the data are not there yet, but we know for people with pancreatoprevic diabetes that have such high risk for hypoglycemia, cystic fibrosis, so many other kinds of patients who might really benefit from an AID system with modulation of insulin dose. Of course, the choice should be made on individual circumstances, preferences, and also needs in terms of also access to what they're actually able to get from their insurance coverage. Next slide, please. So as far as the parental do-yourself, so let me make a parenthesis before I expound on the AID systems. So the do-yourself are right now not approved except for the type loop, which was just approved, but we only have the app. We don't have right now any sort of a configuration that is available to the customers as of yet. The point is, these many systems that we're not waiting have been able to do a lot of very successful tools, and there are data coming out that these are actually not unsafe. The only challenge is that these are not sort of FDA approved. So we cannot prescribe these patients, but should definitely assist the patients into how to manage these systems to ensure they're doing it safely. So always have a backup plan, have multiple daily injection plan as a backup, make sure they understand how to use for hypoglycemia, and also learn, why not, how to do these things. As far as AID, what I want to emphasize is that we all need to know ourselves as providers the nuances of these AID systems, because it behooves us to be able to say, this is what this tool can do, this is what this tool cannot do. And so again, one more time, like Viral was saying, education and training is paramount in setting expectation. This is in the text of the guidelines in the section 7. We don't set expectations, we don't set correct training, we are not helping the patient to succeed with these tools. So we need to know what the literature says about each and every of these more and more systems in the States, but also in Europe. So we need to be aware what are they and what they're due for patients, and also understand how to guide the patient to get to know the system and not misunderstand this stuff, I set it and forget the system, because they're not. We need to train the patient, also if the patient adjusts in symbiosis with this AID system, not really sort of try to fight the system or just be totally passive. So yes, we feel strongly because the literature is there. So the idea was very comfortable saying these tools are helpful for patients with diabetes, but we also need to train the patient and set expectation correctly so that the patient is successful in using these systems when, to take care of their glucose levels.
So thank you for that. And I want to encourage everyone to put your questions in about pumps and automated insulin delivery systems. But I have a question. How do you decide? I mean, we have multiple FDA approved products now. How do you decide what type of pump they should go on?
So you need to know your patients well, because otherwise it can really misguide us. So we have classes in institution where we demonstrate all the tools. That's some sort of a requirement so the patients know what's out there for them. And they wanted to understand, would they want to have a tubeless, a tube pump? That's another thing that is important to understand. Are they super micromanagers? Do they want to work on their basal, or they like to stand hands off? Because all this information will help us to assist the patients in their choice. I tell the patient, I don't buy a car, I don't buy a phone. But at the same time, if you're hating the tubing, you need to look at something tubeless. If you really want to have much more engagement with the basal and bolus changes, you need to do a system that allows you to do that. So again, knowing the system and knowing your patients will help you to guide them in a way, but they need to also be informed, not by just looking on the internet, which they can do. You want them to see somebody just like you, Diana, who explains to them the real in and outs of the whole system, what can do for them, what cannot do, what they can modify, what they cannot modify. So that really helps the patient to make a more educated choice.
Thank you for that. Someone's asking a question if you can describe, and this can be for either of you, the differences between the algorithms between our 3 FDA approved automated insulin delivery systems. Technically we have 4 now, but 3 that are in use.
Right. And I can start, and probably Grazia, please chime in. And so this is how actually I make an analogy through that is that we take a flights every day. Do we really think about that, how the algorithm works to have that flight operate? My answer is no, right? 90% of the flight is automated. Okay, trust me, pilots does only 10% of the work. So similarly, in automated insulin delivery system, what we need to really think about, rather than the math behind it, which is patented and probably most of us don't know, is that what is the modifiable settings that may improve the glycemic outcomes. And so let's say, for example, the Omnipod 5 Medtronic system, both the systems are basal independent system. And what I mean by basal independent is that they deliver every 5 minutes microboluses, if you want to call that microboluses, but it does not take any of the basal rates that you set up in a pump as an, to modulate that basal per se. So they are basal independent systems. So changing the basal rate in a Medtronic system, which is a 770G at this moment, or the Omnipod 5, it's not going to change anything, right? So in those circumstances, like for example, again, I'm going to go by Medtronic 770G, changing the insulin to carb ratio and active insulin time are the two things that helps to improve the glycemic control. So remember that part, two things, don't worry about anything else. In Omnipod 5, insulin to carb ratio, correction for patients' manual corrections and boluses, and the target glucose. And if you say target glucose of 110, that's the best, 150 for someone who needs a little bit of a relaxed glycemic control. And for Tandem Control IQ, everything works except the AIT. Active insulin time is set up as a default 5 hours. You cannot change that. And so for Tandem, it's a basal dependent system. So you can modulate the basal, you can increase the basal rate, but it has a basal clipping of 3 units per hour. So even though if you make it 3.5, it's not going to give you 3.5. It's clipping at 3 units per hour. Rest everything, insulin to carb ratio, correction factor, everything matter. And correction factor in Tandem Control IQ is the most important part because it gives you a 60% of calculated correction as an auto correction every 1 hour if needed, depending on many equations. And so if you have a tight correction, patient might receive a good amount of the autocorrection bolus and may have some low blood sugars. Other way around, the correction is too conservative. It will give you a teeny tiny bolus and probably the patient may have a more prolonged hyperglycemia, particularly after meal. So I know I kind of rushed through that part. There are many things, but my point here is that focus on the things that matters the most.
Yes, but absolutely correct. In addition to that, you also want to understand what is the speed by which the algorithm tries to match. So what is the future? So for example, Tandem projects at 30 minutes and Omnipod 5 projects at an hour. So the longer, the maybe more soft landing, the shorter, maybe a bit more rapid landing in terms of glucose level. You need to understand, explain the patient that the algorithm sees that you're here, wants to put you down here, and it depends how fast it's going to get you there, how fast you're going to go down. And so we need to also explain to our patients how to avoid extra boluses, just have patients optimize bolus calculation, bolus rate, carb ratios. So all of this understanding is not exactly the math, as Viral was saying, but just understand how fast the insulin wants, the algorithm wants to bring down this glucose level, because you will explain to the patient how fast it's going to go to their place or not. And so that's very important to avoid too much hyperglycemia or too much hypoglycemia based on whichever system you're using and their nuances.
Again, that comes out to be in education, right? So we are emphasizing on education and again. So
yes.
Yeah, I love that. And then there was a question earlier about kind of these data management systems. Like, how can people get trained? Like, how do they, know how to go in and understand what's happening?
That's interesting because I had to learn because I had to teach my fellows. So it's practice, really. Practice makes perfect. There are no books on this just yet. So what I would suggest is if a patient is on a system, go and study the actual reports. There are some actual webinars, I believe, in both Medtronic and a Tandem that help you to do that. But if you have one page, just study it, look at the legend, learn the symbols. So that will help you tremendously to understand what all these things in the page mean, and just focus on some of the reports and not too many. I know Viral is a wonderful class that he takes, that he offers to fellows every year, which is wonderful. And also in the society has had some fellow classes for just understanding how to do the data. But I suggest that if you have any trainees in this audience, to just go to these wonderful opportunities, because it really is important to start understanding this before you even graduate. So you really feel more stronger, I should say, when you go into practice, how to interpret this.
Yeah. I just want to add a couple of more lines about that part. So I will just summarize that. And again, I agree 100% with Grazia. What she said is that all it takes is that your curiosity to learn more and then practice it, right? And practice makes us all perfect. So, but few resources out there. Number one, the ADA has a tremendous resources called as Making Diabetes Technology Work. That has a different modules about the CGM, the automated insulin delivery system, how to actually review the reports, how to make an adjustment to improve the glycemic outcome. So that's number one. Number two is, I would say, ADCES. Is it kind of a rename now, or it used to call as a Dana Tech? Wonderful resource about all the BGM, CGMs, and AID system comparisons. So I think that's a really good resource, and that's my go-to resource. But in the past, it used to require that you have a registration or a membership with that organization. But now I think it's a free to all members, if I'm not wrong.
Yeah, it is free. So that you're right. That's a great resource. And then also there's the Panther tools, which are actually on Dana Tech, but also available,
right,
I believe, through the Barbara.
Yeah, it's called as a BDC Panther program. So that was devised by Laurel Messer and her group, and it's a wonderful resource as well. So, and the last but not least, and it's important that find an MSL in your area, which is a medical science liaison, or maybe an representative from those companies, and say, hey, I want to learn about the system. And I'm sure that they will talk to you. They will try to help you to find those resources from their side to help you understand how this technology works.
Yeah, and I also just want to highlight there's a QStream resource also through ADA, which also has some practice on there. But really, yeah, the best way is to practice, just do a deep dive into a report. So at this time, I want to open it up for Q&A for maybe any other areas that we didn't cover specifically in the diabetes tech section, or maybe questions that we didn't get to earlier. So the first question I want to ask you both is about connected pens. Where do they kind of fit into everything? Like, what's their level of evidence, and where do we recommend them in all the tech worlds?
I think they're great tools because, let's face it, many patients are not on pumps or AID system. Majority of people are on multiple daily injections. And so if you can, and our challenge has always been, what dose are you taking? I cannot quantify, but these wonderful connected pen allow you not only to keep track of the doses with timers or even apps, and then you have a combination with sensors. So you can see the bolus that the patient is taking, the dose, and the tracing of the CGM, and really helps tremendously to understand how to best sort of make changes to improve the glycemic outcomes. So that's one, but also the fact that some people might forget to take the dose, and just that you have this timer or this information helps really a lot. What do you think, Viral?
100% agree with you. I just follow you, Grazia, for everything what you do. And so that's the best practice, I would say. And so, again, for us, we need data, right? Without data, what are we going to do? That's why the CGM is the best tool. So similarly, people who opt not to get the pump therapy, there are personal preferences around that, cost around that, tubes, no tubes, whatever, And so if they decide to be on a multiple daily injection, fine with that part. And in that case, the connected pen can give you the data. And once you have the data, then it will help you and your patient to really see what's going on there. There are two most common problems in type 2 diabetes and optimizing therapy is that clinical inertia and then patient's adherence, right? And that can be mitigated by connected pens. So there are wonderful tools, and we should use technologies more often.
I totally agree. Yeah. There's a question about AID. So it says there's a lot of supportive evidence and real world evidence for AID. Why only E level for other types of insulin deficient diabetes?
Because we don't have clinical trials in patients without pancreas. So until we have a stronger level of evidence, even with cohorts. We don't have any of that right now. And so we know that these systems work tremendously because they decrease hypoglycemia, and that's very important. Until we have a cohort that shows that there is some results, the ADA is an obligation to keep the grade lower, because we cannot just put something in the guidelines recommendation without a substantial backing up of this. It's expert opinion because that's what it is so far. We all know in practice they work phenomenally, but we need the data to support and put it out there with the different kinds of level. And trust me, guys, we go with this evidence. Diana knows it. It's so very really detailed. We need to be very secure and sure that what we're putting in there, it's corroborated. Otherwise, we just can't just say whatever comes to our mind. And that's why we need to have a bit more data, even for level B or C, that would allow us to put that level of grade.
Yeah, totally agree. So another question related to, where do kind of basic patch pumps, so ones that, deliver insulin that you can wear, but maybe don't have the increased tech, or even inhaled insulin, like where does that fit in with everything?
I can say that again, and that's again in a language in ADA standards of care, is that individualization, right? So what it means is that it all depends on what your patient has a preference about. And so patient's choice, circumstances, cost of the therapy, insurance coverage, and many things. So I'm sure that we all use those page pumps that maybe in Vigo, maybe a Secure, where this is something I call that something is better than nothing, right? So people who have a challenges in doing bolusing. So let's say, for example, and I'm just thinking about in my head loudly that there are people who have a fear of needles. They don't want to take more than 1 or 2 injections, right? So these kind of devices, even though they are simple, that can help without much complex basal and bolus and insulin to carb ratio. So I think these are great tools, and the more tool that we have, that would actually really cater a large population with the variable needs. And so I think it's a good thing to have.
I agree. It depends on the patient. Privacy, being discreet, unable to bring the pen. One of my patients works in the jail system, he can't bring the pen. So has this little patch, we can take what are we going to do? We got to work with the patient as much as we can. So some situation allow people to have a more adherence to the plan by something that makes it easier for them.
Great. And then I know we're running out of time, but I want to ask one final question about what you kind of think is maybe next, like either through a living update or maybe coming ahead. What things have happened recently that you think could, change the standards of care?
I hope CGM in the hospital and pregnancy in CGM. That's my 2 things. What do you think, Viral?
No, I agree. I think the pregnancy and CGM, now it's an FDA approved, right? So things are, I think, will be in a standard of care pretty soon, and the level of evidence will change. It's there already, but the level of evidence will change. Same thing with the in-hospital. There are a lot of clinical trials, as I mentioned, it's happening, and I'm sure that they will submit the data soon to the FDA. And once it's there, we will have more evidences and we will change that in a standard of care. So yeah, a lot of exciting things happening in this field. And that's what I feel about this field. Like, I give you again an analogy to this, that every September, people are waiting for a new iPhone, right? In a diabetes field, it's the same thing, that every year we are expecting something new, something, that can really improve the patient's care and the outcomes. So that's what we are seeing right now. And I'm excited about those future changes.
Awesome. Well, I think that's a great note to end on. So I really want to thank you both for amazing presentations. It's so great to work with you both, Dr. Aleppo and Dr. Shah. And this concludes today's program. And we also want to thank all of our attendees. We had a great turnout, and this will be available to watch later. We'd also like to thank Abbott and LifeScan for their support of today's program. And be sure to check out our Time in Range resources. Time in Range has launched webinars, podcast episodes, and Practice Pearl videos. And upon the conclusion of the program today, you will receive an email to complete a brief survey. This is not CE credit, but it's just a survey to provide feedback to help us provide even better programming. And thank you again for your time. We look forward to connecting with you at the next Time and Range webinar. Bye, everyone.